Thank you, Tina. Good afternoon, everybody. It's a great pleasure to be here, and thank you to TVS for inviting me to talk about the work we're doing from NHS Improvement around the pressure ulcer programme. So I wanted to give you just a brief background and a little bit about some of the work that we're actually doing at the minute and hoping to be doing in the very near future. And I think, given that you're all here and there's been lots about pressure ulcers already, you're very much aware of the size of the problem. Although I have to say, listening to Lizette's presentation, I find it incredibly distressing to think that those very young, very vulnerable babies are developing that much skin damage, and they're possibly one of our most overlooked populations, and that we should really take that home. But I think sometimes when we talk in percentages, whether we're talking about prevalence or incidence, it's quite a difficult number to capture because we don't know how many patients that is. And so we've tried really hard to put actual real numbers of patients around some of the work we do. So although this data is a little bit out of date, it's the most recent one we can capture. So that between April 2015 and March 2016, almost 25,000 patients were reported to have developed a new pressure ulcer. That's an awful lot of people, isn't it? An awful lot of people. And we know that each month we develop up to 2,000 newly acquired pressure ulcers when we admit them to our care. So they come to us without them and we give them to them. I'm sure you're all aware they stay for longer. And there's lots of different pieces of work that say that can be between 4 days, 6 days, 8 days, in some cases 25 days. Did any of you watch Hospital last night? I was sat in my hotel room, I watched Hospital. I think it's not the only reason patients stay in hospital. One poor man was in for 10 weeks because they couldn't rehouse him. But it shows that it increases the risk. And so on. We've got lots of things around time, about costs, and that doesn't even talk about the cost to the patient. So we understand that prevention of pressure ulcers is a really, really high priority. Kath mentioned this morning this kind of collaborative between the working groups. So NHS England and NHS Improvement, as we know, will be working more closely. There's not going to be a merger. We are just working more closely together. But what we see are initiatives across all the areas talking about elements of tissue viability. So under the banner of NHS England, Kath's talked to you this morning about the Leading Change Adding Value programme. Within NHS Improvement, we have two teams. We have nursing, which is the team I belong to, who are leading the Stop the Pressure programme, and we have the operational productivity team, and Anne will speak to you tomorrow about the work that they're doing. But we are attempting to work in a collaborative way so that we're not repeating work that's done. And in the last session before lunch, there was a very passionate plea from Nikki about let's stop reinventing the wheel, let's stop overlapping, let's work towards the same agendas. So I think that's really important because you may hear about different pieces of work that are being done from different organisations. We are talking to each other, so hopefully you won't be getting lots of questions about the same thing. And the programme was set up because our chief nurse is Ruth May, and Ruth is very passionate about prevention of pressure ulcers. She initially did work around 2011-2012 in Midlands and East region and has picked that up since. So we are now working together to have this concerted programme of work that helps us drive down the number of patients who are developing skin-related harm. So NHS Improvement as the overarching national Stop the Pressure programme, but within that we scoop in the React to Red. We also work with the academic health science networks because we're all working towards reducing the number of patients that are developing pressure ulcers. So the programme itself, it sounds like we're really big and grand when I say our programme. There's my colleague Jenny who works full time. I work 0.6 and Caroline, who's sat behind a pole over there, leads on some of the nutritional work. So she works with us for a very small amount of time, but supporting us around nutrition. And we rely very heavily on the rest of the NHS to support us in the work that we do. So we don't have a full-time admin. There's just Jenny and I doing this. And those kind of petals that you can see there represent all the different types of work that we're doing. And like Lizette, I can't actually read those. They're far too small. So we're looking at design and implementation of a whole host of definitions and standards. So the working groups we've had so far have been very much about trying to standardise definitions. So you will have realised that many people don't use the same language. So some people are talking about category 1 to 4 pressure ulcers, some people are including deep tissue injury, some unstageable, others not. So if you've got 100 pressure ulcers and you break it into 4 categories, then you can have far fewer, you'll have more in each category than if you break it into 6 categories. So there's discrepancy between what's happening. We are looking at developing a more standardised measurement approach. So the original measurement group was around local reporting and measurement and how that happens. So how many places do you record pressure ulcers? You probably all have local dashboards, you have Datex systems, you have SI systems, they escalate up, you fill in so many pieces of paper. But again, there's a real lack of consistency. We've had a national collaborative, and I'll tell you a little bit more about the collaboratives, and we've got an education working group. But it's all working towards reducing harm to patients in relation to pressure ulcers. So the definition and measurement group has been running for almost a year now, and those of you who have been involved will remember there was a consensus meeting back in May 2017, and then we did a second round of consensus via an electronic survey via SurveyMonkey over late summer, early autumn last year. And I know many of those tissue viability nurses in the room are desperate for this piece of work to be published because many of you are writing business plans and a whole host of other things. I can't share it with you yet, but I can share that it's actually got a presence. It's got a front cover, and this is a bit what it will look like inside, because we are in the absolute final stages of governance. It's my task on the train on the way home, along with 6 or 7 other people, to do a final read-through. That's how close we are to this being published. We promised it would be April. It will, I hope, be April. And this is what they will look like. So the statements have been written. So this is the one statement I'm prepared to share that will come out in England. We will use the term pressure ulcer. So there was a lot of debate about whether we would go for pressure injury. We will go for pressure ulcer. And that's the recommendation. And what we've given alongside that is a rationale and a likely impact on what that means for the clinicians and when we expect it to be implemented. So we're not just saying, here's the change. We're trying to say we understand that you can't just wave a magic wand and that will happen. We understand some things will have a big impact, some things most of you are already doing. And I think for a lot of you, you will already be doing a lot of what is recommended. The education work stream has been a very big piece of work, and it's one of the work streams I've been most involved with, so I'm going to tell you a little bit about that. We were, one of the things that people said a lot is there's a huge inconsistency in the amount of education and the type of education. And what we see is if people move from one organisation to another, they have to do the mandatory pressure ulcer education again, even if they only did it last week, because we don't know what they were taught in organisation A compared to organisation B, and that's ridiculous. So what we've put forward is a core curriculum. We considered how we could best do this. We were going to do a big gap analysis of what was taught in universities, but that was actually going to be really time consuming. And we looked at what commercial companies were doing, and what we decided is we would use a framework that already existed. We went through all the published literature to see what was there. But in the UK, it seems that Syskin is something that most people know. So you're all aware of the Syskin bundle. You know what those things mean. There was some publications around developing Syskin, and there was some, so there's Askin, there's Syskin with an E on the end, there are other variants. What we wanted to make sure is that we were covering all the topics we felt were necessary. So what we now have are 10 modules in total. We have anatomy and physiology. If you don't understand how a pressure ulcer happens and you don't understand the anatomy of the skin, it's pointless really doing the rest. We have a core information one. Core information is about being patient-centred, compliance, documentation, just so we didn't have to write it in all the other ones repeatedly. And then we've extended the Syskin to asking with a G on the end, and I have changed the order of the 2 S's and put the skin assessment before the surface. And when the actual document comes out, what you can see on here, I've put incontinence, but we're going to increase that to increased moisture and incontinence, because it's not just about incontinence. And then at the bottom, we've got the new one, which is give information, and that can be giving information to patients and relatives, or it can be give information to other providers, so it may be social care or whoever. And we've got a specific module on device-related pressure ulcers because we feel that some of the content in there isn't the same as the content for the rest of pressure ulcers. So there was some discussion within the group about were we making life complicated by changing skin, and would that affect clinical practice? And our answer to that is no, it won't, because the actions that make a difference are the skin bundle. They're the things that make a difference. You can risk assess a patient till you're blue in the face, it will not stop them getting a pressure ulcer. So skin remains the clinical practice focus. The other modules sit around it. The core information, as I said, has all these components, and we would hope that these, like the 6 C's or the 10 components Kath talked about this morning, should be core elements of what you're delivering as healthcare practitioners anyway, and they should be a core part of standardised care for patients. The modules are presented in a couple of different ways. We have an academic set, which is presented as aims, learning outcomes, and a very brief outline of content. But we're aware that much pressure ulcer education is not delivered in universities or by academic lecturers. So we decided that we would underpin the content with a different framework that was perhaps more suitable for clinical staff developing care. So it's got a lot more detail in, and it's presented at 3 levels. Fundamental, intermediate and advanced, and we didn't attach that to any grade of staff. So with the NHS England work, they've said this is probably suitable for. What we've said in pressure ulcers is that it depends on your existing knowledge and experience. So I'm guessing some of you will work with really well clued up healthcare support workers. So they may come in some of these modules at intermediate, whereas a student nurse might come in as fundamental. So we're expecting some kind of analysis of where people sit. And so the other form of having this detail is that if you are going to do the learning, you can assess your knowledge against them and decide where you sit and what you then need to learn. So as I said, devices have got to be in there in the same way that they were excluded from the NICE guideline scope because they felt that the interventions to prevent device-related pressure ulcers were not the same as to prevent the ones on the bottom. They're going to be different. So we've got that very specific module. When it comes to presenting it, we're going to have both a paper and a digital format. If it was purely paper, it's going to be really big. And I know for many of you don't print paper off. We're going to do it digitally, so there's going to be lots of hypertext linking, so you can hop backwards and forwards between the sections you're interested in. There will be these different sections. There is a mapping section, so if you are that way inclined and you want to know how aims and learning outcomes relate to content or content relates to outcomes, if you're doing this as part of a bigger course, that will be there. There will be a section for reflection and professional development. So this is not university accredited, but we will say this equates to X number of hours. We will encourage people to go and do self-development, self-learning. We are not going to recreate a whole set of resources. What we are doing is looking at what resources are already out there, and we will put pointers to some recommended resources. And they may be ones that you have developed, they may be one that commercial companies have been developed. We will review them and look at their content. All that we'll ask is if they're NHS ones, that you give us permission to reproduce them, that you have appropriate consent for any images that are already in there, and that you are prepared for us to depersonalise them. And I don't mean that we won't acknowledge your trust, but we use very regularly a really lovely video from the Shropshire community team. It's the Red Tomato Stop the Pressure video, and it's really, really good. But the very last slide has the telephone number for the tissue viability nurses in Shropshire, and we use it all over the country. So that's what I'm talking about. We're going to take your telephone numbers and your email addresses out. It will still say your trust. And then it will, of course, have the references. So that's almost in final draft. We've had a really good cohesive working group, but we couldn't have too big a working group. So we've just sent it out to a broader group, learning disabilities, mental health, hospice care, safeguarding, a big group of people to say, we know this won't contain everything you need for your specialty, but if this was the framework, could you add your specialist bits in and use this? And I've got most of those back now. So hopefully that will again be available very soon. So the current working group is national measurement, and we're looking at measurement of incidence and measurement of prevalence, and these are things that challenge people on a daily basis. I know how much people love completing safety thermometer every month, but Ruth's position is very clear. We will not stop recommending safety thermometer until we have something better to replace it with. So the position we're currently in is, with incidents, we're looking to community to pilot this first because we have better digital systems in community. In hospitals, not as many people are on electronic patient record. And NHS Digital are very much of the mindset that you input data once and you mine it a lot of times. So we've gone to one of their areas that are quite advanced in their digitalisation, Birmingham Community Healthcare, and we're looking at their real system to see if we can pull proper incidents out, and we're going to run that alongside some actual testing of incidents. So we're going to triangulate it against a whole host of things. Because we're doing incidents, people said, why are you doing prevalence? You can pull your prevalence from incidents. But we want to do prevalence because we want it as a sense check, we want it as triangulation, and we want to ask some of the more practical questions around what's going on. So are people being risk assessed? Are they being on the right equipment? And we piloted that last week at the Royal Marsden. We've got representation today. I can't see where you are. You're here. Of the 400 odd beds that were placed. She's hiding behind the pole. Everybody's behind the pole. So I believe it went okay, and if that works, we will then roll that out wider. The final thing is the collaboratives. The collaboratives have been absolutely brilliant. We've just completed our first collaborative, 25 organisations. There were 100 applicants. We're about to start level 2, but for me, there were some amazing ideas came from the collaboratives. People were saying we're only doing a small piece of work, we're looking at one ward, we're looking at one community team, but some real creativity. There were also some things that were so stunningly simple, kind of everybody said, well, why aren't we doing that? And there was an awful lot of sharing. So we had our celebration event last month in London, and I thought it was going to be a really hard day because it was 25 organisations doing 5-minute presentations, and it was quite exhausting, but it was uplifting, the work that people had done and what they had achieved. So it was absolutely brilliant, and I'm not going to read those out. They're there. If anybody wants them, you're very welcome to have a copy of some of the quotes of the things that people were doing. So the new work stream, one of the things that was evidenced from our visits is we seem to be focusing on the negative. How many harms do your patients get? And we'd like to do something about positives. How many patients do you actually heal? So how many patients come into your care with a pressure ulcer that gets better? How many patients do you bring in with a moisture lesion that you heal? Or develop some moisture lesion but you actually heal it before they go away because they were very unwell? We are doing a work stream on patient and public engagement. That's yet to be scoped and it's yet to be recruited to. So if anybody's particularly interested in that, we would welcome you coming to join us. And we're going to do one on staffing and skill mix, and there's a draft scope for that in place. But again, we've not yet recruited to that working group. So if you want to be a participant, you are very welcome. So both my details and Jenny's details are there. So Jenny is the programme leader, I'm the clinical advisor. If you want to get involved, it doesn't matter if you are not very senior, not very experienced. We want a range of people. You don't have to come to London every time. Most of our meetings are via teleconference. We try to have one face-to-face, but I try to have one in London and one in either Birmingham or Manchester. So we try to make them that people can get to. So if you're interested in any of them, then please do contact either me or Jenny, and we would love to have you on board. Thank you.